So welcome to the two-part webinar series, Analog versus Digital Removable Workflows in Your Practice. It is a lecture being presented by Tremaine Watkins, CDT. Today is part one, Dentures, Fundamental Concepts, and Analog versus Digital Workflows. And we'll begin shortly. And now it is my distinct pleasure to introduce you all to Tremaine Watkins, CDT. He is the NDX Director of Training and Development. Tremaine Watkins has been working in the dental lab industry for more than 30 years. After graduating with a Bachelor of Arts from Trinity College in Issaquah, Washington, as class valedictorian, he has gained extensive experience in all aspects of fixed and removable restorations, with an emphasis on implant-supported and retained restorations. He also has provided clinical support for case planning, troubleshooting, and implant placement. He has trained other technicians in all aspects of dental technology and has written and lectured on several aspects of restorative dentistry. So it is my honor to say thanks for joining us, Tremaine, and please take it away.
Thank you very much, Jessica. Thanks everybody for joining us tonight. In thinking about how I wanted to present this, I thought I'd start out by kind of going over some, I guess you might say, some market opportunities, some fundamentals of dentures from the analog perspective, and then we'll talk about a variety of different workflows, because there are, in addition to fully digital workflows, there are hybrid analog digital workflows that you can use, so that way you can kind of incorporate digital dentures into your practice more readily. So for housekeeping, I am a full-time employee of National Dentex Corporation. I receive financial support related to the content of my continuing dental education presentation. However, I don't have any other financial or in-kind support by anybody. So without further ado, here we go. So one of the things we want to keep in mind, I think, is what the opportunity is. And I'd say two sides of this opportunity. One side is there's a great financial opportunity here. I kind of tried to break it down, and that means that there's 174, I mean, you can read all the statistics, but there's 174 edentulous people for every general dentist in the United States. So there is a good opportunity for you to grow your practice in this area. We'll talk about some of the frustrations that can happen with analog workflows and maybe why we're not as eager to get involved in this. But let's talk about kind of doing the math and how this all shakes out. If there's about 52 million people, 52 million arches of dentures that are out there right now, so a full mouth would be 2. And if about 8 million are being replaced every year, but if 90% of people are dissatisfied with them, there's a potential market of 42 million arches. And while, as you know, a lot of your patients a bit, this group of patients is going to renew, because every 5 years would be best, as you know, to be replacing your dentures. And kind of to put it in perspective, there's about 2.3 million single implant crowns and 31 million single crowns placed annually. So the denture opportunity could be greater than the crown and bridge opportunity for the whole United States, especially at the get-go as you're getting people into a prosthetic that fits them well. So I think sometimes we look at dentures and we're like, these are a pain in the behind. I don't really want to do them, but we are leaving a lot of business on the table. So we may want to kind of reconsider that, especially if we can find a way through digital to make it very predictable, so that you're not doing 10 appointments for $700, which is such a good deal. So let's talk about occlusion and dentures. I kind of want to start here. Occlusal scheme is, of course, always important, but it becomes critical for a denture because of the effect on stability. Your laboratory is going to set or design your denture to the best of their ability, and hopefully that's really good. But with your advanced knowledge and training in principles of occlusion and articulation, you can often you can coach your laboratory to get an even better result. Let's start with a couple definitions. We're going to define occlusion as the way that teeth come together in a static position, such as swallowing, and then articulation is going to refer to the dynamic tooth relationships while chewing. As you guys know, edentulous and dentate patients tend to articulate differently. Denture wearers tend to chew horizontally with only a slight vertical component, while dentate patients tend to chew in a warped teardrop pattern with much more vertical movement. So because of this different jaw movement, we definitely have to have a different occlusal scheme. So the occlusal scheme needs to be different than natural teeth for two reasons. One, because of the different chewing movement, and second, because how well the dentures seem to fit to the patient, which is often a function of the load on them, is going to vary based on how well we handle our occlusion. So we're going to talk about occlusion. We're going to talk about rather tooth position, both based on an aesthetic and a functional perspective. It's always fun to, dig into some of the more controversial topics. And I would say that denture occlusion can be a controversial subject. I think that historically, people have felt that bilateral balanced occlusion, in which all the posterior teeth contact on the cusp ridges in all possible movements, has kind of been seen as a gold standard of denture occlusion. But as any of you who have worked on this know, achieving that is very, very difficult in real life, both on an articulator and then as we transfer from the articulator to the patient's mouth. Many times what this really looks like in practice is unpredictable lateral interferences on the occlusal surface that can lead to tipping or discomfort for the patient. Because of this, lingualized occlusion has been much more popular. Because the lower teeth tend to be flatter in a lingualized occlusal scheme, which is the B picture here, some people have been concerned that chewing efficiency would be impaired, but studies have shown that when patients use either a balanced or a lingualized occlusion, they get similar real-world chewing efficiency. You'll definitely, obviously, you should follow what you believe is the best clinically, but my advice for severe ridge resorption would be to use a lingualized occlusion, because it's going to be easier for you in the laboratory to make sure that the occlusion is even and eliminating tipping forces. So you guys know that posterior denture teeth are categorized by the angle of the buccal and lingual cusp planes relative to a flat surface. And they're offered a variety of angles, but they're commonly 0, 10, 20, 22, 33, and 40. Usually the teeth with larger angles tend to look more aesthetic. But because of that lateral movement that your denture patients are making in chewing, many times the higher cusp angle teeth, especially set in balance, can generate a lot of tipping force when the patient moves in lateral. So it's best in most situations for full dentures to keep your cusp angles 22 degrees or less. And most of the time when you're doing a lingualized occlusion, you do 22-degree teeth on the upper and then a 0 or a 10-degree on the lower. So definitely be thinking about this, and with all that you know about a particular patient, when you help you can help your dental laboratory get a better result by letting them know what occlusal scheme will be best for a given patient. So when we're thinking about our anterior denture teeth, of course, we want to consider aesthetics, and then we want to kind of tweak our positioning a little bit, our setup, if you will, or our design with a digital case based on articulation. So I have a few rules for tooth position that can be helpful. As you guys know, it's nice to see a 1 to 2 millimeters of incisal edge display at rest, a little bit of gingiva or none at all, depending on patient preference at the high smile. And then of course, you want your incisal angle parallel to your interpupillary line. The other thing that can be really helpful for your laboratory is to use the borders of the nose and mark those on your bite block or on your try-in or on your impression, whatever you're providing. So that way your lab can get a good idea of where the points of the cuspid should be. If a patient is not wearing any denture and you're kind of starting over from scratch, a good rule of thumb is that the labial surface of the maxillary incisors should be 8 to 10 millimeters from the center of the incisive papilla. So that can be a good rule that we use in the laboratories, and you can also use when you're shaping your bite blocks and the like. And we definitely, the other thing I would say is you'll see pretty quickly what a huge effect the tooth position has on the lip. We want to make sure that we're not totally eliminating the philtrum, but at the same time that our patients are getting the lip support that they like. If the maxillary incisal edges touch the wet dry line with a fricative sound, that can also be a good indication that you're getting those teeth where they need to be physiologically. So once we've gotten the teeth, especially for a double arch case where we want them physiologically, we want to kind of look at our what's going to happen when our patient articulates. In general, with full dentures, we want to provide a little bit of freeway space between the upper and lower incisors, and we'll usually have the overjet and overbite the same. So 1 millimeter of both is very common. 2 millimeters will work with some cases, but in general, we'll want to go with a 1 millimeter overbite and overjet. So the teeth aren't touching in centric, but as soon as the patient articulates, they come together. Now, in the anterior, we can get good results if we set the teeth for aesthetics and then modify them for function. But when we're setting the posterior teeth, we really need to be thinking about function as primary. First, we have to set our posterior teeth over the crest of the ridge. If we move them off, especially if we move the functional cusp off the crest of the ridge, we're creating a lever that will tip the denture under occlusal force. That's why your angles classifications are so important on these cases. If the ridges are class 3, we have to set the teeth, the posterior teeth class 3, or we're going to have an unstable prosthesis. For those of us that are used to working with all-on-X or implant supported cases, we have a little more freedom. We can kind of put the teeth where we want them. But with our dentures, we want to make sure that we get the teeth set for maximum stability, because as you guys know, the main complaint of patients with dentures is my denture moves around, my denture doesn't feel very stable. Obviously, our fit's important, and we'll talk about that in a little bit. But getting the right occlusion, with a perfect fit, a poor occlusion is going to prevent the stability that our patients want. Another thing to keep in mind is that you really need to watch your retromolar pad. You do not want to extend your posterior teeth up the ramus. So sometimes you might have to eliminate a molar depending on tooth position, tooth size, that sort of thing. Having 3 teeth on the mandible really isn't as big a deal, but it's really nice to try to get 4 posterior teeth in each quadrant on the maxilla, because that way we'll get a little better drape for the cheeks and the patient will be less likely to experience cheek biting. Although we do want to keep the teeth off the tuberosity if possible. So when we've got our teeth in the right position and we're kind of looking at how everything's arranged, we want to make sure we have balanced occlusion. And in this case, I'm not talking about the difference between balanced occlusion and lingualized occlusion, but I'm talking about we want to make sure that centric occlusion is even, movement in excursions or even, so that, again, so that we're not deliberately putting tipping force into the case. We want to make sure we're using our lingualized occlusion with flat ridge cases, and that for our class 3 and severely atrophic ridges, that we're using a flat tooth. I want to take a minute to talk about denture borders. As you guys know, if the borders are too long, they're going to contact all the mobile tissues around the denture and lead to sore spots and instability. And of course, if we make them too short, our dentures will be less stable because they have less, footprint to reduce the to resist the movement that occlusal force is going to cause. And most labs are pretty familiar with this, but sometimes it's hard to read the anatomic features of the impression, let's say, and sometimes your lab may not be quite as aware of this as you are. So it's good for you to support your laboratory by evaluating the cases, evaluating if they mark the cast for you, where the borders are, and making sure that we get nice borders. We'll be talking about the reference denture workflow, and this becomes especially important with the reference denture because the edge of the borders of the denture have to be set in the impression. So it's really important when you're doing your border molding to pick up all the features that you need. So a special point of interest is the vibrating line. It can be difficult to see that on the model. So if you guys mark that on the palette either and scan it with a color scan or texture scan, or take a physical impression and pick it up on the impression, that really helps, because a lot of times we're guesstimating that spot. And if we know exactly where it is, we can put our post-stem there if we decide we want one. You don't have to have one with digital dentures. And that way we'll make sure we get as much suction as we can for the case. So we've talked a little bit about like the theory of dentures, or how you might do a denture case. So let's kind of focus on how we do an analog case. I mean, I don't think this will be news to most people. I'll kind of flip through it, but this is, I would say, the baseline. And as we're talking about digital dentures, we'll kind of compare and contrast the digital workflow with analog dentures. So as you know, if you want to, the first step in doing a denture case is a preliminary impression. Alginates are great for these if you want to, if you can pour it up, or if your laboratory is close by, or you can use alginate PVS if you want to send them to one of our laboratories. But if you are pouring your impressions, make sure your team mixes the stone nice and thick and extracts any bubbles, so that way we get we're off to a good start on the case. So your laboratory will make you a custom tray to help pick up all the borders and features that you need, and then you'll take your master impression at this point. It's a good idea to do border molding at this time, so that way we can capture all the features that we need and make sure that we're getting the most stable dentures that we can. It's a single arch. You can go ahead and capture the posing impression at this time. So your lab will pour your master models and box them, trim them carefully to make sure that we have all those borders that you work so hard to capture. And then we'll make the bite blocks. I feel like bite blocks are one of the underutilized features in dentistry. When your laboratory gets the bite block, basically what they're going to try to do is set the teeth so that the buccal surfaces of the teeth are aligned with the buccal labial surface of the wax. So if you shape up the wax so that the buccal corridor looks good, the lip support is good, all that stuff, you'll find that all of a sudden your setups get a lot more predictable. So a little bit of time spent contouring the bite blocks can give you much better results for your setup. And that's the case whether you're doing a hybrid digital workflow or if you're doing a traditional analog workflow. Once you get the wax shaped up where you want it, of course, you'll want to trim if you're doing a double arch, trim the maxillary arch so that the plane of occlusion looks really good, and then carefully trim the mandibular arch until the person achieves the correct vertical dimension of occlusion. Once you know where that is and it's repeatable, you can go ahead and cut some retentive grooves in the occlusal surface of the bite blocks, put a little bite material in there, have the person bite together, asking them to try to touch in the back. That'll, as you know, that'll help them get to a CR position. Send that to your laboratory. So your laboratory will go ahead and articulate the case with your bite block and then set the denture teeth in wax based upon the guidance you've given them. Usually the base plates that you've sent that were used for the bite block are the same ones that you'll get back for the try-ins. So however the case fit at the bite block appointment, it'll probably fit the same at try-in. One of the challenges, as you guys know, with the analog workflow is you really can't evaluate the fit of the case at this point because your laboratory has to block things out so that they draw. So the base plates usually fit a little looser than the final denture will. So you kind of have to make a judgment call. You know, is it fit like 90% of what you want and it'll probably get picked up, it'll get improved a little bit in processing, or is it maybe 65% of what you want and you should probably do a reline inside to make sure that you have the correct tissue shape? If you're not sure, it's better to take a reline impression inside the base plate at the try-in stage. So after the wax up, your laboratory will make any changes necessary to the setup, then process the denture. One other thing I would say about the traditional workflow is that it's probably best to always take a crown and bridge bite material over denture setups. The reason being that sometimes your patients have an easier time biting correctly or in a way that works for them when they have teeth that are occluding, as opposed to when they have two big blocks of wax. So it kind of gives your lab an opportunity to refine that bite and get it working as well as possible. Your laboratory will use a lost wax process of one kind or another to turn the base into plastic, acrylic, and return it to you. So as you guys know, there are some parts of this process that can be frustrating because in some ways, every time you get an analog denture, you're kind of starting over. So you had the bite block, and so the fit will be the same at the try-in most of the time, but now you got teeth, and the teeth can often be in a little bit different position. But even from the setup to the finish, sometimes the teeth move during processing, different things like that. So you might have had a setup that was perfect, and you're like, what the heck? How come the final is different? And unfortunately, it's been part of the analog process, because even when the lab is meticulous and you are as well, there are just some things that can go awry unpredictably that can lead to problems with the case. The current denture workflow was perfected in the 50s, and as you know, it can work seamlessly. Every once in a while, we get a case finished in 5 appointments that we discussed. But with average chair time, you're talking $1,350 in office costs in addition to laboratory fees. So because of that, many times analog dentures are so unprofitable that we just choose not to do them. And as the appointments pile up, it just gets worse and worse and worse. When you add extra try-ins at the front end and adjustments at the back end, it's not hard to see why many offices avoid doing dentures. I've kind of put this cranky little graphic on the slide because, as a lot of you know, this can kind of be where things degenerate, is towards the end of the process. The patient's like, well, I thought I was going to get this or that, and I'm not happy with the fit, or I'm not happy with the tooth position, or whatever. And there are most of the time there's post-delivery adjustments. Resin, we'll see this on the next slide, but resin shrinks about 8%, even high quality resin when it's polymerizing. So a new denture technically does not fit completely perfect. Tooth delamination, you guys know that's always kind of a problem. The first thing is each tooth is its own thing in a traditional analog denture. Secondly, it was embedded in wax. So as part of our processing step in the laboratory, we do everything we can to eliminate that wax. But if there's just a little tiny layer on there, it works as a separating agent, and it can cause the denture tooth to delaminate, which is, of course, a frustration. Breakage can occur because we follow generally accepted procedures to make sure our base plate is thick enough, but you can't always tell how thick it is. And then last but not least, you get your lost dentures. You've worked hard, you've gotten the case done, and you're like, all right, I got something awesome. And then the patient loses it, and you're like, oh man, you think about everything you went through and you got to start all over again. Another source of frustration. So let's talk about how digital workflows can eliminate some of these problems and make the case work better for you. The first thing is the fit. On the bottom right, you see an image of a CAD/CAM denture and a pack and press denture. And the green areas are areas of perfect adaptation. You know, we often think of dentures as being retained by suction, but what it really is by accuracy of fit. So a well-fit denture is going to have more retention than one that doesn't fit quite as well. Oftentimes on the maxilla, to try to create suction on a traditional denture workflow, we'd have to carve a post-dam because the denture was going to shrink. It wouldn't fit perfectly even on the day of delivery. And so we have to kind of compensate for that. With a digital denture, they're printed in 50 micron increments or milled to whatever the accuracy of the mill is, which is usually a crown and bridge margin. So essentially perfect. So you're going to have a much higher level of accuracy for your fit. Your tooth bonding procedures are different too. If the denture isn't made in one piece, when we bond the two-piece dentures, usually the teeth are one set, and then they're bonded following a procedure similar to how you do direct bondings of composite in the office. So there's no wax to interfere. We prepare the denture teeth with adhesives and basically bond them to place. So chances of tooth delamination with a digital denture are very, very slim. The first generation of printed denture materials were not as good perhaps as they could be, but this new generation, we're getting very, very high strengths. One very popular digital printed product has a flexural strength of 200 newtons compared to the ISO standard of 79, which is really the best of injected dentures. So we've gotten to the point now where the actual material that your denture is made out of is superior in terms of strength. You can preserve the manufacturing files. If my recommendation for you would be to ask your laboratory and say, hey, can you send me the files that the denture was made from? Us labs, we generate lots and lots and lots of files every day. And so we often have to kind of get rid of older files, or else we're not going to have the space that we need. Our computers run slower, et cetera, et cetera. So if you save it in your patient's digital file, then you'll have it for them. I would recommend also when you get the STLs, make sure that you record what kind of material was used. This is a fast evolving field, and that way your lab will be aware of what processes need to be done with the STLs if you guys decide you want to, you need to replace a missing denture or something like that. I think for people who do a lot of digital dentures, they would say the best thing about the process is continuity. So in other words, when I take my initial scan and then when I go to my try-in and I go to my finish, things stay the same unless I want them to change. There aren't built-in parts of the process that can lead to unpredictable changes like packing, investing, divesting, different things like that. We're able to start with a given plan and make any changes that need to be made can be made predictably. So that way, you know, and you can, instead of opening the box, getting the patient in the chair and like, well, I hope this works, you can be like, okay, I have a good plan. I know this is going to work well. So let's talk about the different workflows that you guys can use for digital dentures. And so we'll kind of compare and contrast with the analog process that we talked about. We can talk about doing analog records and going to a digital denture. We can talk about a couple different ways of doing digital records and going to a digital denture. And then we can talk a little bit about facial scanning. And so we'll go over these processes. So if you don't have an iOS system, that's okay. You won't be able to benefit from all the fit advantages of a digital impression, but you will be able to benefit from the predictability, the cool things you can do with a printed try-in, and the predictability of the digital denture process, even if you continue to use the workflow that you have. I would say a reference denture workflow is probably the best digital denture workflow in 2024. Statistically, 80% of your edentulous patients have some kind of denture that will fit in their mouth. And so if you can get them to bring that to their records appointment and you do an impression reline, a bite over it, and some photos, we can get right to a try-in as the second stage. If you have a patient who doesn't have a denture or won't bring it, and you want to do a more advanced workflow and get to 3 appointments, you can get an impression and take a mush bite. And of course, you can just add one more quick appointment and do a bite block. That then your bite block, you can use the reference denture workflow. One of the cool things about the facial scanning workflow you'll see is that you can even get your digital denture workflows down to 2 appointments. So let's talk about how you might do these different workflows. What I'm going to focus on is like, here's a digital workflow, and then we'll talk about how the other ones vary somewhat as opposed to going through all the steps every time. So the first appointment in the analog digital workflow that we talked about, the hybrid workflow, are those same for an analog denture that we discussed. You can take preliminary impressions, do a custom tray if you want, or directly take your master impression. You'll need to use your normal border molding. Your digital denture will fit accurately, like we talked about, to whatever data you give. So the variability will be the accuracy or master impression. So the little investing a little extra time, making sure you get that awesome border molded impression will result in you getting the most benefit from the advances in fit of a digital denture. So if you do that workflow, then you're going to a bite block appointment next, unless you decide to do a mush bite. This is kind of a picture of a mush bite. So what that is you get some dental medium viscosity putty, usually a 2-part, mix it up and put it in the patient's mouth, have them bite down slowly until they hit the vertical dimension of occlusion. And then you'll want to contour the bite so that it doesn't distort the patient's face, because it'll kind of serve as the bite block for your laboratory as they're designing the case. You can trim your buccal of the mush bite to show the correct tooth position so you get adequate lip support, and mark with a scalpel all the things you normally would: low, high smile, midline, cuspid positions, all those things. So that way, if you do a traditional impression of mush bite, your second appointment will be a try-in. If you don't want to do that, then your second appointment will be a bite block. So most labs are still doing, you can print your base plates and some labs are doing that, but most of the time, just given printer capacity and the like, it's a little bit easier to do a traditional bite block on these cases. And you'll go ahead and use all the techniques we talked about before to tell your laboratory what they need to know from the bite blocks. From this point forward, though, the workflow becomes entirely different. So what you get back at the next appointment after you've recorded the bite registration is a printed triant. So basically what this is a final denture design where the pink part and the tooth part have been merged into one object and then printed in usually a triant material. This is a very sturdy material. So you can send your patient home and do a triant, let them try it out basically, so you can get a little additional feedback. You can pretty much do whatever you want with this. If you want to mark on it, as you see in this image, feel free. If you need to shorten something, you can shorten it. If you want to add a little bit, you could add some composite if you wanted to. If you're not satisfied with the fit, you can take a reline impression in it. Your laboratory can rescan the case and make update the fit, because this fits the same as the final denture. The final denture, unlike with the analog process, the intaglio is exactly the same. So you don't have to wonder, will it fit better? Will it fit worse? It'll fit, the final will fit exactly the same. So this is one of the ways that this process adds a lot more predictability to your dentures. So once any changes have been made to the design, your laboratory will scan in additional data if necessary and go ahead and finish the design. Laboratories kind of are doing, there's three main workflows today. One is milling the denture. It gets a nice result, but it takes a long time in the laboratory and it's kind of hard on the equipment. So you're not seeing as many people doing that today. The second workflow is using special carded teeth that are designed for digital dentures. So the intaglio surface of them is shaped kind of like an ovate ponic to fit nicely into the denture base. Or your laboratory can print the base and mill or print the teeth. I think that's the most popular option in 2024, both because there are some great printed materials for teeth finally, and because then if there isn't a lot of restorative space, it's not as big a problem. Carded denture teeth can't be adjusted like stock denture teeth can. So you have to have a lot of vertical space for a carded tooth. So most labs have found it's very predictable to do the printer mill teeth and the printed base. But make sure you talk to your laboratory. I think that just like all of you have materials that work well in your hands, your laboratories are the same way. So if you talk to your laboratory and kind of hear about what works well for them and you tell them what works best for you, you guys can come to a great understanding and get yourself and your patients the good, consistent results that you want. The latest generation of iOS systems do allow the possibility of taking an accurate edentulous scan, but this technique can still sometimes be difficult clinically. And I feel like there's a couple challenges. One is intrinsic to the process, and one is more of an equipment variable. Intrinsic to the process is that, as you know, we're going to be scanning mobile tissue. So as you put the scanner in the mouth, you're actually moving the borders. And so it can be a little bit challenging to get a good scan. So you'll need to kind of practice your technique to be able to capture all the data that's needed. Some of the older generations of scanners just weren't that good at scanning tissue. And so it really wasn't a regular thing. The second thing is the way that we scan. The more that we get into the world of iOS, the more we're discovering how important scan path is. And so I've got a little screenshot here of from Dr. LaRusso, an Italian prosthodontist, who has found that scanning in this pattern gives the best result in terms of accuracy and predictability. So if you do want to take an IOS of the tissue, you're welcome to do so. So if you're doing this iOS workflow, you either will need to take a mush bite again or have a bite block made. Once you've taken that scan, your workflow will be pretty much the same as the analog digital workflow that we've discussed. The one cool thing about taking an iOS, as you know, is that the holy grail of denture fit is mucostatic impression. And by definition, since the iOS isn't pushing on the tissue, you're getting a perfectly passive impression of the tissue. So not only do you have the accuracy of an iOS, but you know that you're not depressing the tissue in any areas. You're less likely to have sore spots and things like that. So now I want to move to the reference denture workflow, which I would say is the most predictable for digital dentures in 2024, and probably the one that you'll want to try to follow because it'll give you a smooth, predictable path to a well-fitting, good-looking dentures. Remember, 80% of your patients have a denture. They may not be wearing it, but when you talk to them at the pre-treatment appointment and say, hey, we're going to be taking your impressions, I need you to find a denture to bring to the office, most of them will be able to help you out with that. Now, most of the time, you're going to want to paint some adhesive on the denture to make sure that the impression material adheres. But keep in mind, you can kind of get yourself in trouble by adjusting a patient's existing denture. So you'll want to make sure you have a little bit of IPA to wash off that adhesive. So the first thing you want to do is evaluate the denture and see if there's any major missing areas. And if so, you'll probably want to support those areas with a little bit of compound, as you see on the left. If the denture is more or less has the right footprint, you can go ahead and start out by syringing your heavy body material around the edges of the denture like this, and then doing your border molding movements. Once that's set up, you can go ahead and use a light body impression over the whole area, go through your border molding one more time. When you're doing the border molding, it's best to hold the denture manually so that way the patient doesn't displace it. This will get a very nice fitting impression for you, and you can do it fairly readily, and you'll be able to remove this once you've done your scan. So once you have your denture realigned with the impression material, you're going to have a much better fit. So now you're ready to take some pictures of the patient wearing that realigned denture. You'll want to trim any excess that's come way up over the teeth, so that way the patient, we can see the teeth in the photos, and you can take nice photos like you see here of the smile, and then also lateral views, so we can have a better idea of how the patient's face is looking and if there's any alterations we need to make to the denture to support that. As with this patient, you can see the patient's a little bit overclosed, so you can use a leaf gauge or another instrument of your choice to get the patient to the correct vertical dimension of occlusion before you take the bite. It can be nice to go ahead and take a PVS bite material just because it makes the case easier to scan, to make sure you're scanning it in the right position. So once you've gotten your relines and your bite, you're ready to go ahead and take your scan. So you'll start out by taking a 360 scan of the denture. What this means is that you scan both the cameo surface and then you transfer over onto the realigned tissue side, so that way at the end you have a STL, PLY, whatever output file you like of the entire denture. So you have a 360-degree representation of the denture. Scan the opposing, which in this case would be another denture, but could also be the natural teeth. And then you'll want to scan the bite. When you're taking the bite, please be sure to scan both sides of the arch. Even if the files seem to stitch together after the first scan. Taking that second scan makes the bite much more accurate. Sometimes we'll get files in the laboratory where the teeth from one arch are penetrating the other one, and then we know that the bite isn't accurate. And something that can really help with that is scanning both sides of the arch. There is a workflow that you can do like this that involves taking a mush bite, using the mush bite as kind of the intaglio of the mush bite as a custom tray, and then relining it with impression material. It's a little more advanced workflow, but if you do that, then you can do a 360 scan of the mush bite or send it to your laboratory to scan it on their scanner, and then it'll definitely allow you to get to a try-in at appointment 2 as opposed to adding an appointment in between for a bite block. So once your laboratory has those files, the lab will be able to design your new denture. I like this picture. If you've never seen how the design process goes at a laboratory, the bluish purple is the existing denture, and the yellow are the teeth that are being designed. So your laboratory can superimpose the bite block or the setup or the reference denture right over our design to make sure that we're making very precise changes or no changes if the person really likes their denture. In general, we'll go ahead and once we have the bite, we'll go ahead and design the teeth, get you that printed try-in, and then be able to move to finish. Again, I wanted to emphasize, get those manufacturing files from your lab and put them in your patient's digital file. And then that way, if you ever need another denture, you can send them to the laboratory. The laboratory can manufacture them without any try-ins or whatever. Just manufacture, assemble, and send them to you. The last workflow I want to talk about is facial scanning. If you think about all the things that you send to the laboratory beyond the master impression, most of the time they're an approximation of the patient's face. And here's what I mean. We've talked a lot about bite blocks. And if you think about it, what a bite block is it shows a thing that properly supports the patient's face and sits correctly within the patient's face. So if your laboratory puts the teeth within that envelope, they'll work for the patient. But it's not the same as seeing it in the patient's face. Let's say you send a study model. What a study model is it's something that looks good, we think, in the patient's face. So we don't know that our design will look good in the patient's face, but we know that if we match this, the old thing looked good, so probably the new thing will look good too. One of the cool things about modern facial scanners is that it basically allows you to capture a three-dimensional image of the patient's face that can then be aligned to the intraoral scans so that we can actually design our cases within the patient's face. So we're not using proxies for the face. We're actually moving the teeth around and sizing them and positioning them right within the patient's face. And I've seen a bunch of these cases delivered. I've seen 4 or 5 delivered. And it's kind of funny because you have the computer screen next to the patient. You turn the image in the screen so that it's looking at you the same way the patient is, and it looks exactly the same. It's really cool. I think this will be the thing. At some point, we're going to be doing all our cases, designing the face, and we'll be like, why did we ever do this any other way? So kind of be looking for opportunities, I'd say, to do this. What I see on the screen is exactly what I see in the mouth. And so what becomes cool is that you can show your patient virtually, like using the exocad web viewer or something like that, the setup, let them look at it, give you any feedback, make changes. We can make changes laboratory, do it again, and if necessary. And then you're not even doing a try-in. So you do facial scan in iOSs, virtual try-in that doesn't have to happen in the office. and then delivery. So this gives you the ability to do a 2-appointment denture. So your second appointment is the delivery of the denture. And I'll show facial on photos, but these are not the same as like the camera-based apps, because you can turn this image any way you want. You could tip the person's face up and look at the way their maxillary teeth align with the lower lip. You can turn to the side, look at the profile. You're just like we can turn the models in the virtual space any old way we want. We could turn the face any old way we want. So it becomes really cool. I definitely believe this is the next step in digital technology and digital denture technology. So, you know, as pricing becomes more attractive for facial scanners, I think you'll find that these really help your practice and get you the predictable results that you want. So like we talked about, your lab is going to have a preferred manufacturing process. From a theoretical perspective, additive manufacturing is better than subtracting, which means that 3D printing is intrinsically superior. It has less waste, works more quickly. But materials are the bugaboo in that. A couple of years ago, I would say milling definitely had the edge because a milled PMMA was the sturdiest thing that we could get. With the current generation of printed materials, we're finding materials that meet or exceed the strength of that PMMA. So now printing, I would say, has the edge. In addition, milling takes a long time, so your lab can produce less cases in a given time. And hard plastic materials are actually harder on the equipment than zirconia, believe it or not. So your lab's going to go through more spindles. There are some great milled products out there, so your laboratory can get you a good result with printing or milling. But I would say if you poll the laboratories that you work with, and certainly within our national Dentex network, 3D printing is the manufacturing process du jour. Talk to your lab, but I think you'll find that that most of your labs are milling, and the new milling materials just work great for you and your patients. Copy dentures. You probably don't see a lot of this, but especially with some of the design software we're using in the laboratory, we can make an exact copy of the denture. And if you send us the denture, we can make that. If you do a nice 360 scan of the denture, we can do that. I'm sure you're not going to see a lot of this, but if you have a patient that wants it, we definitely can deliver that today. Most of the time, if you're doing one of these cases, it would probably be good to do a reference denture workflow. In other words, to do the impression reline, just to make sure we're getting the most superior intaglio adaptation that we can. There's probably not a huge market for this, but it's good to have this in your back pocket and just keep in mind that this is a possibility for yourself. Immediate dentures. These are a really nice workflow. The main thing is when you're taking your scan with your iOS, you want to make sure that you capture the depths of the vestibule, the tuberosities, the past the vibrating line, the retromolar pad. So you need to take a big denture type scan, not a small Cranbridge type scan, if you will. If you want a little, we can extract the teeth digitally, which is nice. We can do a little bit of reduction if that's what you like. In general, in the laboratories, if you don't say what you want, we'll tend to remove the teeth right at the right there at the free gingival margin, so that in effect, when you do your extractions, there'll be a little bit of space inside there, because it sure is easier to fill the space with linol than it is to grind it down. And then once you've delivered that temporary denture, you can use it to do the reference denture workflow for the final restoration, which can be really handy too. So basically 2 scans like you take for study models, and you're ready to go for an immediate denture and basically work your way through that whole process digitally. Printed over dentures. There are some really nice advantages for printed dentures for overdentures, because the material's intrinsically stronger. It'll stand up to the to the additional load of an implant retained denture, which can be really handy. I don't really have the time to go through the whole workflow, but keep in mind that the digital workflows that I've seen right now do not allow the laboratory to position a model. We don't have scan bodies yet for our attachments. So if you use the scan, we don't have scan bodies rather that allow us to position analog. So if you use the scan body, what it'll do is it'll make a very precise hole in the intaglio of the denture, and you'll go ahead and place the female attachments chair side. So another thing where keep it in mind, because I think you'll really see the benefits in terms of decreased staining, decreased breakage, better fit, more comfort for your patients. That's it. That's what we have today. Thank you very much for attending. You can feel free to reach out to me through Jessica if you'd like to get some more information about any of these topics.